Well, it's working. If it's working, why do you keep telling me it's not working? Okay. Okay, yes, it works. Now stop. Good morning, good morning, good morning. Okay, that seems to work. All right. Okay. Good, 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 good. Okay. Definitely by Thursday, because that's when I'll spend most of the time writing the test. So if I don't have them by then, if you get them done on Friday, of course, that's gonna be too late. So the earlier, the better. Give me a chance to look them over and yes, this is good. That's better. Tweak this. Blah blah blah. Bob's your uncle. There you are. 50. 50. There'll be multiple choice and true false. So I was asked by my good friend Chuck White, when you make up tests, why don't you just repeat all your old questions? And I told him, number one, because things changed in this field. So there's new data, new materials, stuff like that. Two, I do reuse the occasional old question. So from a test, you'll see probably a third of the questions will be old questions, but I usually end up writing new questions. So that's why test writing for me ends up being a very time-consuming enterprise. So the discussion board went up yesterday. If you're going to write me some masterpieces, please do so by tomorrow, because that's when I'll spend most of my time writing the test. So I will need them by Thursday. The exam, the goal is to have 50 questions, multiple choice and true false. And usually with a 50-minute class, 50 questions, there's plenty of time to do that. If you cannot take the test in class, let me know. I can have a test sent over to the Academic Connection Center. You will then need to call Mrs. Holloway, Amber, and make an appointment. It's very nice over there. They have, it's nice and heated and it's quiet and what have you, but then you have to make an appointment. So let me know. You can make an appointment over there. Some people won't be here, so they will have to make an appointment. Other than that, Mrs. Schaefer is out because she had a medical procedure of some sort. She's still out of sorts, not able to come back, so we can't just assume she'll be here. So I'm going to be depending a lot more on the Academic Connection Center. Okay, I think that's everything before we get started. So to start with, please turn to page 31 in your handouts. I'd like to show you something before we get into it all. And before we start, we should, of course, have a word of prayer. So, Lord, we come to you again today, a little colder today. Thank you for every student here. I know some people are struggling with illness, others with injuries, others with family mishaps and what have you. So we pray for those who are injured, those who are sick, those who have family situations and what have you. Lord, we want to cast all our cares on you because we know that you care for us and that your care for us is in very unique, very tangible, and very personal ways. So, Lord, we come to you today and we ask that you would now personally help us to learn this pretty abstract and very difficult material. In Jesus' name, amen. Very good. So we have the summary of these different types of adrenergic receptors. Now, adrenergic means it has to do with adrenaline. And adrenaline is an old term for epinephrine. So epinephrine and its sidekick, norepinephrine, these are released by sympathetic postganglionic nerves. That is their neurotransmitter, particularly norepinephrine. And then norepinephrine and epinephrine together are also released by the adrenal medulla. In response to activation of the sympathetic nervous system. So these particular hormones / neurotransmitters, so they function as hormones in this case, and they function as neurotransmitters in this case, so they do double duty, which drives students nuts because you can call them hormones or neurotransmitters. So they can bind to these array of adrenergic receptors. There are two main classes of adrenergic receptors, alpha and beta. There are also subtypes of alpha and beta receptors. So there is an alpha 1 and an alpha 2 receptor. beta 1, beta 2, beta 3 receptors. D receptors refer to dopamine receptors, so we won't concern ourselves with those just yet. Let's talk mostly about these alpha receptors first. So the alpha 1 receptors are predominantly found on the surfaces of smooth muscle cells that surround blood vessels, and in particular, blood vessels that are peripheral. So it says most of your vascular smooth muscle, and then you can see it's also responsible for the pupillary dilator muscle. So activation of the sympathetic nervous system causes the pupils to dilate. That's a result of activation of the alpha 1 receptor. It also is responsible for the hairs that stand up on the back of your neck. They activate that pilomotor smooth muscle that causes goosebumps. And it helps the prostate contract. And there are a few in the heart. The role they play in the heart is minor, but there are a few in the heart as well. So the biggie, if you were to take your highlighter and highlight these, the one you'd want to highlight the most is that top one. They are going to predominantly cause vasoconstriction of peripheral blood vessels. Now, if you constrict blood vessels, what's that going to do to blood pressure? Is it going to raise it or lower it? Raise it. You're increasing peripheral vascular resistance. Since you're increasing peripheral vascular resistance, you're raising blood pressure. So alpha 1, when activated, will raise blood pressure. Alpha 2s. Alpha 2s are predominantly found in the central nervous system. And they are an autoregulator. When the presynaptic neurons release norepinephrine, that norepinephrine also binds to the synaptic terminus, to the alpha 2 receptors on the synaptic terminus, and they tell that neuron, okay, that's enough of that. Let's not make any more norepinephrine. You've done enough norepinephrine releasing. Let's just stop that. So this is autoregulatory in the central nervous system. So if you activate alpha 2 receptors in the central nervous system, you decrease norepinephrine production by noradrenergic neurons. So it's autoregulatory. And we saw last time these particular drugs, methyl-dopa and clonidine, these are alpha 2 agonists. So they bind to the alpha 2 receptor and they tell neurons that make noradrenaline, that's quite enough. So if we think of a neuron, and I have to warn you again for some bad artwork, it's about to come your way. Okay, use your imagination, pretend that's a neuron. It's a pretty lousy one, but it'll work for now. So this is your cell body. These are your dendrites. I can see the tigers just looking at you. Some of you are like, all right, just humor me, okay? These are your dendrites. That's your cell body. This is your axon. That's your axon terminus. This neuron will receive signals at the dendrite. You get a graded potential here. You then get a proper action potential going down the axon. When you get here, there's calcium gated, there's voltage gated calcium channels Calcium's let in, you release your neurotransmitter. And the neurotransmitter is found in all these vesicles. The alpha 2 receptor is found at the synaptic terminus of those neurons that release norepinephrine. So norepinephrine, as it builds up in the synaptic cleft, will eventually bind to that receptor, and it will tell the neuron not to release any more norepinephrine. So if enough of this builds up in the synaptic cleft, so that some of it now binds that receptor, you don't release any more norepinephrine. That's how those alpha 2 receptors work. So they are predominantly receptors you find in the central nervous system. So alpha 1s are found peripherally. They're going to cause blood vessels to constrict predominantly. Alpha 2s are found in the CNS. They're autoregulatory. Now we get to the betas. There's an alpha 3 receptor as well, but that's found mainly in the bladder. So we're just going to ignore that one for now. Beta 1s are found in the kidney and in the heart. The big one's the heart. And you can see they will increase the force and the rate of contraction. Force and the rate of contraction. So if we put Caitlin over here on a treadmill and we take the whip and we say, run, and she runs, and she runs, her heart's going to increase its rate in order to deliver blood to those working muscles. And we say, faster, 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 and we use the cattle prod. So she goes even faster. She's going to run faster, her heart has to beat faster to deliver blood to the muscles, because if part of the muscles work, they need more oxygen. So that increased heart rate is caused by increased norepinephrine that's being delivered to the heart. When we finally relent and we're done torturing her and she gets off the treadmill, then the heart rate will go down. The amount of norepinephrine now being released will be lower. Beta 2 receptors. Beta 2s are found in skeletal muscle. Skeletal muscle. They're also found in vascular smooth muscle that surrounds the vessels that lead to skeletal muscle, and in the smooth muscle that surrounds the uterus. It's also found in the human liver, where if it's activated, you degrade glycogen to glucose to get fast energy. So again, our example, when Caitlin gets on that treadmill and we say faster, 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 her muscles now will start to become anaerobic. What do those anaerobic muscles need? Glucose. Now, if we haven't been feeding her sugar cubes, or if she hasn't been to the DC in a bit, she's going to get that from muscle glycogen. Muscles only store so much glycogen. They're going to need glucose from another source, and that will be the glucose that gets stored in the liver. So that's the second part of what norepinephrine is doing. It's not only making the heart beat faster, it's increasing blood supply to skeletal muscles, and it's providing sugar to feed those muscles. And this leads to a group of drugs we won't talk about in this class, but it illustrates this point here. So beta 2s are also found in smooth muscle, particularly smooth muscle of vessels that feed skeletal muscles. Smooth muscle that surrounds the uterus. Also smooth muscle that surrounds the airways. So if we activate beta-2 receptors, the bronchial smooth muscle will relax. You can draw in more air. So we tell Caitlin, run, run, run. She needs air, right? That epinephrine will cause her body to take in more air. You'll also get more blood going to skeletal muscles, so she can keep up with the treadmill. Now, uterine smooth muscle, if during pregnancy you start to get premature contractions, the thing about contractions of the uterus, they follow a positive feedback loop. So small contractions can start to add up, and if it's too early for the baby to come, then one of the drugs you will give will actually take this smooth muscle and it will prevent it from contracting anymore. These types of drugs are called tocolytics. Tocolytics. The same tocolytics that bind beta-2 receptors in uterine smooth muscle and prevent it from contracting can also bind to the beta-1 receptor and cause your heart to beat really fast. So the main drug that's used here is called terbutaline. I think I misspelled that. Yeah. Terbutaline, and terbutaline is a very effective tocolytic, but it'll make your heart jump out of your chest sometimes because it also binds those beta-1 receptors. Then the beta-3s, as you see, when activated, they will activate the mobilization of fat stores from adipocytes. So what does this have to do with blood pressure? Well, think about the beta-1s. Yes. Braxton Hicks are right before you give birth, so usually very, very slight. If it would lead to birth and the baby would be way too young to survive, then yes, they would use that. So my youngest daughter, when she was in utero, she got a little active and she kicked her placenta, and the placenta started to pull away a little bit, and Carolyn started to have contractions. So she called the hospital, and one of the OBs here at Jackson, Dr. Farhat, he said, she said, yeah, I felt a kick and then felt a little bit of pain, and I started getting contractions. He said, you better come in. We need to take a look at it. It might go away, but it might not. So let's just be safe. Let's have you come in. So she went to the hospital. They hooked her up to the monitor. Sure enough, the placenta was giving way, and those will heal on their own. But with contractions, the placenta will now start to erupt even more, and then the baby you have to give birth to the baby. And Emily at that stage was 21 weeks, so that's way early. So they gave Carolyn some tocolytics, and Carolyn said her heart did a nice little giddy up, but the contraction stopped and the placenta healed, which placentas are very good at doing that. And all was good, and Emily came right on time, and all is well. So that's, yeah, that worked in our case. But again, every woman who's taking these drugs has said that her heart really beats fast. In some cases, extremely fast. Okay, so beta-1 receptors, if you activate beta-1 receptors, what does that do to the cardiac output side of our blood pressure equation? Your heart rate goes up, so does cardiac output go up? Yeah, let's review our little equation. So CO does not mean Colorado. That means cardiac output. So is this a potential target to control blood pressure, that beta-1 receptor? Sure it is. Sure it is. There's a whole group of drugs called beta blockers that are going to address that receptor. Alpha ones, those cause vasoconstriction. That'll increase peripheral vascular resistance. Is that a potential target for blood pressure regulation? Sure it is. Sure it is. There's a whole group of drugs called alpha antagonists that they're not used much today anymore, but they were designed to control blood pressure. Alpha-2 agonist. Is that a potential place to control blood pressure? Well, sure. There's a drug right up there. That's exactly how it works. Now, it's not used so much for blood pressure today. It's used more for ADHD. But you can see, if you understand essentially these receptors and their role in the sympathetic nervous system, you can start to see how agents are designed to control blood pressure. And we call things essentially that will inhibit sympathetic activation, we call those sympathoplegics. And drugs that activate the sympathetic nervous system are called sympathomimetics. They mimic the effects of the sympathetic nervous system. So pseudoephedrine, which you find in decongestants, cough syrups, that's a sympathomimetic, where these others are sympathoplegics. Brooklyn? Slides aren't moving. Oh, doggone it. Now they're moving. They're moving now? Great. Okay. This is the part about Zoom that is just infuriating. Okay. Now they're moving? Okay, he's okay, good. All right. Very good. So beta blockers are drugs that antagonize the beta-1 receptor. Some beta blockers are specific, relatively specific for the beta-1 receptor. Others are not. So the term that is usually applied to the specific, the selective, beta-1 selective beta blockers is called cardioselective. And usually if the beta blocker, if its name, generic name starts with A through N, it's usually cardioselective. So A all the way up to N, not including N. And then if it begins with N through Z, it is non-selective. Non-selective. So a potential side effect, therefore, for beta blockers that are non-selective is going to be that they can make asthma a lot worse because they'll cause constriction of bronchial smooth muscle. Whereas your cardioselective ones will be much less likely to cause that. Alpha blockers, beta blockers are all going to end with the ending laughing out loud. So my stupid mnemonic is blood pressure is no laughing matter. So laughing out loud, that's your beta blocker. So like a 10, atenolol, propranolol, metoprolol, nadolol, pindolol, your mother-in-law dolol, so on and so forth. If it ends in lol, it's a beta blocker. Alpha blockers you can see end in zosyn. So prazosin was the first member of this group, followed by doxycycline and then terazosin. These aren't used that much anymore because people tend to become resistant to them. Now, prazosin has a second life, if you will, in that it is used these days for people with post-traumatic stress syndrome, because people with post-traumatic stress syndrome tend to suffer from nightmares. Turns out that these drugs can prevent the nightmares and promote sleep. So prazosin gets used a lot more to promote sleep in people with post-traumatic stress syndrome. They are also used for older men with benign prostatic hyperplasia, BPH, where the prostate gets bigger and it prevents urine from being able to pass through the urethra because the enlarged prostate will compress the urethra. These essentially will decrease the constriction of the urethra. So that's what they're used for. They're not used so much for blood pressure anymore. So the kidney is the one organ that can regulate blood pressure indirectly, but because it regulates blood volume, it will very effectively regulate blood pressure. So by increasing the amount of liquid that the kidney excretes, you can pretty effectively decrease blood pressure. The kidney works very hard to maintain its perfusion rates. That way it makes sure, number one, the kidney gets enough blood for its own function. Two, it makes sure that its filtration rates are relatively constant. The kidney does this in one of two ways. First of all, the kidney has an autoregulatory function where blood vessels that come into the kidney, if the kidney is not getting perfused well enough, vessels leading to the kidney will dilate. And then the vessels leaving the kidney will constrict. That causes more blood to flow to the kidney and it keeps more of it, makes more of it stay there. If that doesn't work, that's called renal autoregulation. That's a local response. If the kidney really feels like it's getting gypped when it comes to blood supply, then it tries something a bit more systemic and it secretes this enzyme called renin. Renin is an enzyme and it will degrade a protein made by the liver called angiotensinogen. Angiotensinogen. So this is a 57 kilodalton protein. So as proteins go, it's on the small side. And this particular protein will be clipped by renin into a small peptide that's called angiotensin 1. Angiotensin 1 is then going to circulate through the capillary beds in the lungs. And in the capillary beds in the lungs, it will experience this enzyme, angiotensin converting enzyme. And that clips angiotensin 1 into angiotensin 2. Angiotensin 2 is a potent systemic vasoconstrictor. A potent systemic vasoconstrictor. There's an experiment you can do in the laboratory. You do it usually with a rabbit. You take the rabbit, you anesthetize the rabbit, and you expose the femoral artery, which is easy to do in a rabbit because the femoral artery is really big. You can take a little drop of angiotensinogen 2. You can put a little drop of that on this vessel, and that vessel literally right before your eyes will go from this to just like that. It will just shrink and you can hardly see it. It will constrict so much. Why is the kidney doing this? The kidney is constricting blood everywhere else, so the blood all flows to the kidney. So this is a systemic red alert by the kidney that says, okay, enough of this, give me the blood. Angiotensin 2 substantially raises blood pressure. The other thing angiotensin 2 does is it stimulates the production of this steroid hormone, aldosterone. Aldosterone is made in the adrenal cortex. By stimulating production of aldosterone, aldosterone will cause the kidney to retain sodium and excrete more potassium. So now your sodium levels go up. Because your sodium levels go up, you're now going to have more liquid go from the interstitial fluid into the bloodstream. So it constricts vessels and your blood volume goes up. That's going to really raise your blood pressure. So angiotensin 2 production and angiotensin 2 activity, as you might guess, is a target for blood pressure medicines, for several of them. So a bit more on renin. It's made by this group of cells in the kidney called the juxtaglomerular apparatus, or the JGA, because juxtaglomerular apparatus doesn't quite roll off the tongue. So if you take a nephron, that's the structural unit of the kidney, you blow it up right there, you can see where you have the Bowman's capsule, where your afferent arteriole feeds into the Bowman's capsule to form the glomerulus. You have the ascending distal convoluted tubule, passes through it. There's some cells that connect it to the afferent arteriole. Those cells with the high cells that you can see that form that tubule, that distal convoluted tubule, that entire apparatus there, the mesangial cells with the so-called maculodental cells, that whole thing is called the juxtaglomerular apparatus. So they detect the amount of blood coming into the kidney. They also detect the filtration rate of the kidney. And if blood flow goes down and filtration rates go down, it will secrete renin into the blood supply. So efferent, afferent arterioles, mesangial cells, the macula densa cells. Macula densa are the high cells of the tubule. Here's a cartoon kind of showing the whole thing, and you get the picture. So this is positioned right at a spot where it can easily monitor blood flow into the nephron and filtration in the kidney. And this is the arrows there show you essentially the macula densa and then the mesangial cells. There's the arteriole, the smile there, that's the arteriole. That whole gemisch there, that's the JGA. So instead of seeing it in a cartoon, you can actually see it in a slide. It looks a little squished because that's what happens when you fix it and then section it. You squish it a bit. That's why the arteriole kind of looks like it got run over by a truck. That's what happens when you section things. They get squished. Now, turns out the cells of the juxtaglomerular apparatus, they also have beta-1 receptors in them. So sympathetic nervous system activation will also cause the excretion of renin, as will drugs that stimulate the sympathetic nervous system. And those will culminate in the production of angiotensin II, which will substantially raise blood pressure. So the angiotensinogen is clipped by renin into this peptide right there. You take the very front end of angiotensinogen and cut it off. That's what renin does. So it's a peptidase. You now have this peptide that's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 amino acids long. So that's the 10 amino acids from the front of angiotensinogen. That's angiotensin I. That circulates through the bloodstream. It gets to the lungs on the surfaces of the endothelial cells of the capillary beds of the lungs. You have ACE, angiotensin converting enzyme. It's going to take those last 2 amino acids there, the histidine and the leucine, and it's going to clip them right off the carboxy end. And that peptide right there is angiotensin II. You can see it is a 1, 2, 3, 4, 5, 6, 7, 8. I count that right. 1, 2, 3, 4, 5, 6, 7, 8. 8 amino acid long peptide. And it binds to a receptor, the AT receptor, the angiotensin receptor. There's an AT1 receptor and an AT2 receptor. The AT1 receptor is the one that mainly regulates blood pressure. Angiotensin II is then degraded by angiotensinase, and angiotensinase degrades it, as you can see, by taking that glutamic acid off the front, aspartic acid off the front, and now it becomes a non-functional peptide that's just excreted. Angiotensin converting enzyme further raises blood pressure by degrading this small peptide called bradykinin. Bradykinin is a vasodilator. So angiotensin converting enzyme will degrade bradykinin to an inactive peptide. So if you inhibit angiotensin converting enzyme, you not only decrease the production of angiotensin II, you also increase the production of the half-life of bradykinin. That will further lower blood pressure. Angiotensin II binds to its receptors, and AT1 and 2 are its receptors. And again, AT1 is the main blood pressure controlling receptor. And so to lower blood pressure, you can inhibit angiotensin converting enzyme. There's an entire group of drugs called ACE inhibitors. ACE inhibitors. And you have some lists of ACE inhibitors on page 40. And you'll notice all your ACE inhibitors end in PRIL, pril. So benzapril or benazepril, captopril, enalapril, lisinopril, lisinopril, moxapril, quinapril, ramipril, trindolapril, your mother-in-law pril, whatever. They end in pril, they are an ACE inhibitor. You can also design molecules that antagonize the AT1 receptor, the angiotensin binding receptor. And these are called angiotensin II receptor blockers. These drugs you will see end in sartan, sartan. So candesartan, iprosartan or B-sartan, losartan, olmesartan, telmesartan, your mother-in-law sartan. If they end in sartan, they are a angiotensin II receptor blocker. There are some other drugs that are simply vasodilators. They have their uses. They're used mainly for emergencies. There's one drug we'll get to that is a vasodilator that is not used for emergencies. It's used for everyday use. And that is a drug called hydralazine. Hydralazine. Many of these others are used mainly for emergencies. You have a list of these in your handouts. Oh, here we go. Yeah. Page 36. So minoxidil, the topical minoxidil is used for hair growth. That's Rogaine. But the oral minoxidil is used for hypertensive emergencies. And one of the side effects of it was if you give it to women, women start growing beards. That's where people got the idea, oh, maybe we could use this to help guys grow the hair back. And so topical minoxidil, that's what it's used for. It's used to help people keep their hair or grow it back or what have you. All right, so this is a makeshift drawing of a nephron. And this is meant to show you where some of the different agents that increase urine production work in the nephron. This particular group of drugs collectively, because they increase the amount of water that you lose, therefore decreasing blood volume, therefore decreasing peripheral vascular resistance, therefore decreasing blood pressure. These drugs are collectively known as diuretics. Diuretics. So that yellow thing there is meant to be Bowman's capsule. The tubule that emerges from the Bowman's capsule is called the proximal convoluted tubule. That then goes into the thin descending and thick ascending loop of Henle. Then you get to the distal convoluted tubule and then to the collecting duct, which then leads to the renal pelvis, which then goes to the ureter, which then goes to the bladder and out the urethra, so on and so forth. So a few of these drugs, as you can see, work in the proximal convoluted tubule. The one that tends to work the most in the proximal convoluted tubule is this one, acetazolamide. Acetazolamide is not used for blood pressure control these days because it causes you to lose bicarbonate, and bicarbonate's a pretty important buffer. It is used for high altitude sickness. So let's say you decide to go to Colorado, and you get to Colorado, you're going to do some hiking. So you hike up to 10,000 feet. All of a sudden, you start puking your guts out, something fierce, and you have to call mountain rescue to come get you off the mountain because your electrolytes are so screwed up because you puke so much. They will give you acetazolamide because you're suffering from high altitude sickness. And they'll give you an IV as well. So this particular drug is a member of a group of drugs that inhibit an enzyme called carbonic anhydrase. So they're carbonic anhydrase inhibitors. They have their uses. They're just not used that much for blood pressure. Acetazolamide is the prototype drug of that group. Osmotic agents are also not used so much for blood pressure control because they can cause you to lose a lot of water. Where they are used is if someone has too much liquid in the brain. So they have increased intracranial pressure. You can then use an osmotic agent to try and get rid of that extra pressure. So this includes drugs like mannitol, other types of drugs like that. Not usually used for blood pressure control. The ones that are used for blood pressure control include the thiazides, the loop diuretics, and then the aldosterone antagonists. So those are the ones we will cover. So the loop diuretics work predominantly in the loop of Henle, the ascending loop of Henle. The loop diuretics are the most potent of the diuretics. The thiazide diuretics are going to work predominantly in the distal convoluted tubule up there. They'll decrease salt recapture. And then the aldosterone antagonists, they're usually going to work over here in the late distal convoluted tubule and the collecting tubule as well. All right, so to give you a bird's eye view of how each of these works, carbonic anhydrase, which is abbreviated CA, don't mistake that for California, that's carbonic anhydrase. This is an enzyme that is ubiquitous, absolutely ubiquitous. So this particular enzyme so the bicarbonate buffer system is by far the most prevalent in your body. It's really important for buffering your blood and other fluids. So carbon dioxide and water will combine to form carbonic acid. Carbonic acid will disjoin to bicarbonate ion and a hydrogen ion. Carbonic anhydrase is going to increase the rate of this reaction. And this enzyme is found inside cells, it's found outside cells, it's found bound to membranes, it's everywhere, just everywhere. So that's a reaction it catalyzes. So if you think about how the kidney works, the tendency is for the kidney to save bicarbonate. So you have these two different types of carbonic anhydrase. One of them will convert carbonic acid to carbon dioxide and water. Both of those can enter the kidney cell really easily. Inside the cell, you convert it to carbonic acid. Now it's trapped inside the cell. That disjoins to bicarbonate and hydrogen ion. The bicarbonate gets recaptured by a chloride bicarbonate antiporter on the basal surface of the kidney cell. The proton is pumped back into the filtrate by a sodium proton antiporter. So you recapture sodium that way, you spare bicarbonate, and this is how you keep bicarbonate and are able to recapture sodium. Pretty ingenious system here. What happens if you block carbonic anhydrase? If you block carbonic anhydrase, now that bicarbonate is going to end up in the filtrate. You have increased bicarbonate in the filtrate, you have more solutes in the filtrate. If you have more solutes in the filtrate, you have to have more solvent in the filtrate. That means the ability of the kidney to recapture water is decreased because there is no active transport of water in the kidney. How do you take up water? You take up solutes and the water follows it. So you recapture glucose, you recapture sodium, you recapture bicarbonate, you recapture, whatever. The water comes along for the ride. You leave the solutes in the filtrate, guess what? You don't take up much water. So you have more solutes in the filtrate, you leave more water in the filtrate. That increases the amount of water that you lose. Therefore, let's go back to our you decrease blood volume, you decrease peripheral vascular resistance. You decrease peripheral vascular resistance, you decrease blood pressure. So these will lower blood pressure, but you're losing bicarbonate. You want to keep bicarbonate. That's why they're not used traditionally to regulate blood pressure. They're used for other things. So these are the carbonic anhydrase inhibitors. The one that's used the most is acetazolamide because it's cheap and it's an old drug. And these are some of the others. Again, they have their use, but not usually for blood pressure. Now, loop diuretics work in the thick ascending loop of Henle. The thick ascending loop of Henle is permeable to salt, but impermeable to water. Permeable to salt, but impermeable to water. So you have this very powerful pump that pumps back sodium and potassium and chloride into the cell of the thick ascending limb. And then you have a variety of channels and pumps that will recapture these back into the bloodstream. Loop diuretics will inhibit that pump all this chloride and potassium and sodium. If you leave all that salt in the filtrate, as you get to the DCT and the collecting tubule, you'll now have a lot more solute in the filtrate. You have a lot more solute in the filtrate, you're going to have more water in the filtrate. So you're going to lose a lot more water. And that is one of the big caveats of this diuretic. Very high water loss, so you're at risk for dehydration, and very high sodium and potassium loss, so you're at risk for low potassium, hypokalemia, low sodium, hyponatremia. So people who are on these types of diuretics really have to watch their salt and water intake. These are loop diuretics, are very effective. Furosemide is the prototype of this group. It's an old drug. Because it lasts 6 hours, the trade name of the drug was Lasix, last 6. Lasix is a drug you may have heard of because it's used a lot. Other drugs include bumetanide, torsinide, and ethacrynic acid. Now, if you look at furosemide, bumetanide, and torsimide, bumetanide goes by the trade name of Bumex. Torsimide, I forget. If you look at those three, what do you see in those three that's common? Sorry? No, the molecule. What do you see in those molecules that are in all three of them? What's S? What's S? Sulfur. Do people have allergies to sulfur sometimes? Yeah. So if you have a sulfur allergy, you can't have those drugs. This particular loop diuretic, ethacrynic acid, does not have sulfur in it. So that's the one you can have if you don't have a sulfur allergy. Thiazide diuretics are very widely used. They're going to work in the distal convoluted tubule. They will inhibit a symporter that brings in both sodium and chloride. So by recapturing sodium and chloride, you also re-enhance the capture of calcium. And you can see that here. If you inhibit this, you keep that sodium and that chloride in the filtrate. You keep that sodium and that chloride in the filtrate, you're going to lose more liquid. You lose more liquid, you decrease blood volume, you decrease the systemic vascular resistance, you decrease blood pressure. Thiazide diuretics are very widely used, and they're used to control blood pressure predominantly. If you have a patient who has, say, heart failure, they're retaining a lot of water. So you're giving them powerful diuretics. They're losing a lot of potassium. They have to be usually on a low salt diet in the first place. So the potassium intake is usually not great. There are also diuretics you can give them that will spare the potassium so that their potassium levels can stay in the normal range. And there are a group of diuretics that are potassium sparing diuretics. They work in the proximal distal convoluted tubule and in the collecting tubule. So in the collecting tubule, you have a so-called intercalated cell, and you have a principal cell. And the principal cell has these channels, and those channels are controlled by this hormone aldosterone. So you have two types of these drugs. Spironolactone and eplerenone antagonize the aldosterone receptor in principal cells. Whereas amiloride and triamterene, they are going to inhibit the sodium channel. You inhibit the sodium channel, you won't be losing potassium in that case. So you either prevent the synthesis of the channel or you prevent the function of the channel. Both of those will cause you to spare potassium. You won't be kicking potassium back out into the filtrate. Now, two of these drugs, notice they're steroids. Spironolactone and eplerenone are steroids. that's one of the reasons they're going to antagonize the aldosterone receptor, which is itself a steroid. Very good. Okay, we'll have our test on Friday. And then Monday, we will get into the precise use of these in a clinical setting to lower blood pressure. Yeah. Very good.